break. This session is on Young Investigators Workshop, combined APASLAASLD and ASLD. My name is Dan Yook Young. I'm from Singapore. And it's my pleasure to have Professor Iwakiri as a co-chair. Introduce yourself.
Hi, I'm Yasuko Iwakiri from Yale University.
Okay, can I just check if Dr. Nipun Verma is here? Okay, if not, then what we'll do is we will push forward the schedule and we will invite our next, the second speaker to start off with today's session, Dr. Pruksa Ananchusuk from Thailand. Our topic today is on the ALBI grade and platelet count to predict high-risk varices in hepatocellular carcinoma. Dr. Pruksa.
So, good afternoon, Chairman and everyone. Thanks for the opportunity to present my research, modify ALBI grade and platelet count to predict high-risk varices in patients with hepatocellular carcinoma. So I have nothing to declare for this study. Okay, let's begin with the background. The occurrence of variceal bleeding in HCC patients was significantly associated with mortality, and previous data has shown that primary prophylaxis, either with EVL or beta blocker in patients with high-risk varic in HCC patients, improve survival. Therefore, to predict high-risk varic in HCC patients, it's essential to indicate the prognosis and also provide prompt intervention. Currently, the Room11 criteria promote non-invasive tests to identify portal hypertension and also recommended endoscopy for variceal screening in cirrhotic patients with liver stiffness by transient elastography of more than or equal to 20 kilopascal or platelet count less than or equal to 150,000. However, the study using Room11 criteria to detecting high-risk varic in HCC patients receive conflicting results. Therefore, right now, there is no recommendations of to select the patients to do the endoscopy in HCC patients. The albumin bilirubin score or ALBI score predicts survival and assess liver function in HCC patients and has been mentioned in the Barcelona 2022 guideline. Previous studies studied the combinations of ALBI score and platelet count by calculated from ALBI grade part 1 point for platelet more than 150 and 2 points for platelet count less than or equal to 150 and found that this score demonstrates the good diagnostic performance to predict high-risk varic in HCC patients and showed an excellent negative predictive value of 98.1% to exclude high-risk varics in HCC patients. Therefore, our study aimed to validate and refine the previously studied albumin, bilirubin, and platelet score for predicting high-risk varic in HCC patients. Next is about a method. We retrospectively include patients with HCC and had EGD report at King Chulalongkorn Memorial Hospital, Bangkok from 2019 to 2023. Patients with prior GI bleeding were excluded. High-risk varic in our study was defined as F2 or FT varices on EGD report. The liver function test and platelet count were retrospectively document that we choose the nearest one to the EGD and not more than 6 months before EGD. The ALBI score was calculated as shown in the slide. The ALBI grade and modified ALBI grade were classified as shown in the table. We calculated ALBI platelet score according to previous study from Chen et al. And our study proposed the modified version of ALBI platelet score by calculated combined 1 point from modified ALBI grade 1 or 2A or 2 points from modified ALBI if patient have modified ALBI grade 2B or 3 plus 1 point from platelet count as shown in the slide. We use standard statistical analysis for this study. Next is the results. Of 564 HCC patients, 277 patients with EGD results were included in our study. The characteristic of enrolled patient is shown in the table. Most of the patients are male, about 80%. The mean age is 66.42. Most of our patient has cirrhosis type A, around 90%, and there are 47.3, 30.7% and 22% of patients with HCC Barcelona staging A, B, and C respectively. The mean platelets count of all patients is 167,000, and the mean LB score was minus 2.38. There are 38 participants with high-risk variants in our study. The mean platelet count in patients without high-risk variant is significantly lower, and the mean LB score in patients without high-risk variant is significantly higher compared to patients with high-risk variant in our study. On multivariate analysis, the modified LB grade 2B and 3 and platelet count less than 150,000 is significantly associated with high-risk variants in HCC patients with an odds ratio of T.49 and 3.92 respectively. The area under the ROC curve of LB score and platelet count for predicting high-risk variant in patients with HCC. The LB score show AUROC of 0.755 and platelet count show AUROC of 0.738. Next section, we're going to discuss about LB platelet and modified LB platelet score. Of entire cohort, there are 28.5% of patients with LB platelet 2 and 36.8% of patients with modified LB platelet score of 2. And the higher, and as you may see in the slide, the higher proportion of patients without high-risk variant has LB platelet or modified LB platelet 2 compared to patients with high-risk variants. This slide shows the sensitivity, specificity, positive predictive value, and negative predictive value of platelet count, LB and modified LB grade, and LB platelet and modified LB platelet score at each cutoff for predicting high-risk variants in HCC patients. Combining LB grade and platelet count show the excellent diagnostic performance for predicting high-risk variant in HCC patients. Both LB platelet and modified LB platelet at cutoff 2 show the excellent sensitivity of 97.4% and 94.7% and receive the comparable high negative predictive value of 98.7% and 98% respectively. To summarize, high-risk variant was significantly associated with modified LB grade 2B and 3 and also platelet count less than or equal to 150,000. The area under the curve of LB score and platelet count for predicting high-risk variant were acceptable. And LB platelet and modified LB platelet at cutoff 2, which equal to patients with LB grade 1 or 2A and platelet more than 150 show excellent diagnostic performance. For LB platelet score of 2, is received negative predictive value of 98.7, and for modified LB platelet 2, is received negative predictive value of 98%. Our study have several limitations due to the retrospective nature, and our study is the tertiary care center, so only 36% of enrolled patients being new case. However, actually it's present the real-world situation of HCC clinics, which has mixed new and treated patients. So I think this score can be applied in real-world situations. And secondly, there's a gap between lab value and EGD. However, the median duration between them is only 13 days, so I think it's not affect the lab change during this time. So, in conclusion, modified LB grade and platelet at 150,000 showed significant association with high-risk variant in HCC. And moreover, our study proposed that HCC patients with modified LB grade 1 or 2A and platelet count more than 150,000 may avoid AV surveillance. Thank you for your attention, and I will be delighted to answer to the question.
Thank you. This will put the floor open to the floor for any questions and comments.
Very interesting observation. So, being a basic science, probably I will ask you some maybe off question, but why you started to look at albumin platelet ratio for this study? What is the significance of looking at those values?
Yeah. For platelet count, it reflects the portal hypertension in patient with cirrhosis and maybe in HCC. And also, LB score reflects the liver reserve in patients with HCC. Previous study used non-invasive tests, including transient elastography, which may be confounded by tumor. But I think LB score, which calculated from albumin, bilirubin, and platelet, is not affected by the tumor at all, and it's the easy tool to calculate that even in the center that have limited resource. So that's why I'm interested in this score.
I see. Can I ask one more question related to your answer? So are there any direct relation to the platelet or platelet phenotype to the HCC progression and so on?
That's the interesting question. Yeah, from my literature review, I found some research that talk about platelet type and also even distribution Y of the platelet that related to the HCC and also portal hypertension. However, because of the retrospective nature of our study, we don't have those data, so that's why we didn't analyze that. But in the future, if there is further analysis, I think it could be the good research question.
Thank you.
Yeah.
So thank you for a very clear presentation. So I noticed that you recruited this patient from your HCC clinic.
Yes.
How extrapolatable is this to the regular general cirrhotic clinic?
All of the enrolled patients had HCC, and if you look at the baseline characteristic of the patients, first, most of our patients, actually all of our patients is compensated. Around 90% is cirrhosis Chi A, and about 10 to 20% is Chi B. So first, I think it can be applied in compensated cirrhosis patient. Secondly, we validated in patients with HCC with, in our entire cohort, we include all staging. So I think it can be applied to all.
Did you have a chance to validate this in the non-HCC patients?
No. However, from my literature review, there are 2 studies in cirrhotic patients, and it found an excellent diagnostic performance as well.
In the patients who had a portal vein thrombosis due to HCC, did you notice whether they still followed this correlation, or because their portal hypertension was the pathophysiology is different? Yeah.
Actually, there are 71% of patients with portal vein thrombosis, which account for only 10% of patients in the study. And I have do the univariate analysis, and it found non-significant associations with HCC. So I'm not sure whether it's because of the small number of patients or because it's not associated.
One more last technical question. This was a retrospective review of the endoscopy pictures. How many endoscopists were involved in this study in your center? And do you have a standardized protocol for collecting pictures? And if you did any measures to control for the reliability or reproducibility of interpretation of your staging for varices?
Okay, so Actually, in our center, the endoscopists are both trainee and faculty. However, in our study, we review the picture of the varices as well to confirm that it's F2 or F3 or F3. Yeah.
Did you also, maybe last one, do you have a chance to also look at the high risk with red whale sign and so on, besides just the F2, 3 size, but high risk stigmata?
I didn't collect that data. Yeah.
Any other questions from the floor? Okay, if not, thank you very much for the presentation.
Thank you.
So our next speaker, which you probably won't find it in your book, is Dr. Ho Agnes Yu Yen. Her topic is on the effectiveness of non-selective beta blockers on preventing hepatic compensation and mortality in hepatocellular carcinoma.
Good afternoon. Thank you for having me here to present my findings of the study on the effectiveness of non-selective beta blockers in preventing decompensating hepatic events and mortality in patients with hepatocellular carcinoma. So just to introduce myself a bit, I'm Dr. Agnes Ho from the Prince of Wales Hospital of the Chinese University of Hong Kong. I don't have anything to declare for this study. So to start with, as you all know that clinically significant portal hypertension, defined as more than 10 mmHg of the hepatic venous pressure gradient, is a significant and critical stage beyond which liver-related complications arise, including the ascites, variceal hemorrhage, hepatic encephalopathy, spontaneous bacterial peritonitis, and hepatorenal syndrome. Meanwhile, non-selective beta blockers have been known for a long time of its effectiveness in reducing the portal pressure, making it the gold standard of variceal bleeding prophylaxis, no matter primary prophylaxis or secondary prophylaxis for many years already. In the recent years, there are numerous studies to support that because of the pathophysiology and the mechanism of reducing the portal pressure, non-selective beta blockers are also effective in reducing the risk of hepatic decompensation in patients with clinically significant portal hypertension. So our study targets mainly on patients with HCC, in which this is a group of patients where most studies actually exclude them when studying on the non-selective beta blockers in preventing hepatic decompensation. But we see there are a few important reasons for us to focus on this group of patients. So first of all, hepatocellular carcinoma is a global health issue because of its high incidence and also low survival rate, in which hepatic decompensation also plays a very important role in HCC. The liver function reserve is a crucial prognostic factor, and hepatic decompensation is also the leading cause of HCC-related mortality. Patients with hepatic decompensation also have limited treatment options, including, for example, liver resection. Apart from that, the pathophysiology of developing portal hypertension in patients with cirrhosis are quite different from patients with HCC. In HCC, the portal hypertension increases mainly because of the presence of arterial venous shunting within the tumor, also because of the change in liver architecture due to the presence of the tumor, and last but not the least, also due to the tumor invasion into the portal vein and its branches. Not to say that there is a scarce evidence of non-selective beta blockers treatment effect in patients with HCC, as mentioned just now, because most of them are included in the studies, likely because of the high mortality and many confounding factors. Because of the growing evidence in the effectiveness of non-selective beta blockers in preventing hepatic decompensation in patients with compensated cirrhosis, we wonder whether non-selective beta blockers can actually exert similar effects in patients who developed HCC. So that's how our research questions arise. So let's go to the methodology. Our study is a territory-wide retrospective real-world cohort study. Data was retrieved from the Clinical Data Analysis and Reporting System, the CDAS, of Hospital Authority of Hong Kong. Just to give you some ideas what the CDAS is. It's actually a system that covers the electronic health records from all public hospitals and clinics in Hong Kong. So it includes all the patient's demographics, medical history, procedure records, laboratory results, and also medication records. Because around like 80% of the patients actually attend the public hospitals in Hong Kong, so it's actually, the data set is actually representative of around 80% of data from the Hong Kong population. So we identified all individuals who were diagnosed with HCC and had esophageal and or gastric varices from 1st of January 2000 to 31st December of 2020. So there are a number of patients that we excluded from the study population. So this included patients with who were less than 18 years old. So the patients we included were mostly adults, and patients who were pregnant at the time of HCC diagnosis, or if they were co-infected with human immunodeficiency virus, HIV, or if they had liver transplantation in 6 months before the enrollment, or if, because it's a retrospective study from the data set, so if from the data, the date of the death was recorded before the date of HCC diagnosis, we excluded these patients as well. The primary endpoint of our studies was a composite endpoint of hepatic events, defined as the first or further hepatic decompensation, including ascites, variceal hemorrhage, hepatic encephalopathy, spontaneous bacterial peritonitis, and also hepatorenal syndrome. And our secondary endpoint is the liver-related mortality. For the baseline state, we set today as the date of HCC diagnosis, in which the demographic data, all the lab results, for example, the liver function, the INR, the prothrombin time, the renal function, etc., we collected within the 6 months of the baseline date. We also collected information on relevant diagnoses related to the etiology of the liver cirrhosis, for example, the viral causes or alcohol-related liver cirrhosis, and also collected data on the pre-existing cirrhotic complications and comorbidities. Procedures related to the management of cirrhotic complications, for example, the ascitic drainage, we identify them by the coding as well. And drug information, for example, the chemotherapy received or the beta blockers or the DM medications, etc., were identified the relevant drug code, identified the drug information by the relevant coding as well. So this group of patients were followed until death. So either they had liver-related death or non-liver-related death, or if they have liver transplantation, or till the last follow-up date, which was set to be the date of data retrieval, or till around 5 years of follow-up, whichever came first. So moving to the statistical analysis, we use the SPS and the R software to do the analysis. Cumulative incidence function of the first or further hepatic decompensation with the adjustment of competing death and liver transplantation, and liver-related mortality with the adjustment of non-liver-related mortality and liver transplantation were estimated by Gray's method within 95% confidence interval. So the regression model we used was the cost-specific hazard model, and also after multiple imputation, and it was implemented for the univariate and multivariable analysis. A time-dependent covariate was adopted to model the change in the treatment. So this included the change from non-selective beta blocker users to the non-selective beta blocker users. Also, if they have it otherwise, for example, started with the use of the non-selective beta blockers, but later changed to non-selective, they changed to non-selective beta blockers non-users, we allow this change with the time-dependent covariate. The baseline covariables, the indicator of first or further hepatic decompensation, and the Nelson-Allen estimator of cumulative hazard were included in the imputation model. Covariables included in the multivariable analysis were selected by backward elimination method. All the statistical tests were two-sided. Sorry for the typo here. And the statistical analysis was taken as the p less than 0.05. And we also performed a subgroup analysis in our study, in which patients with the use of beta blocker, we defined with the duration of the non-selective beta blocker use by 90 days. So either they use more than 90 days or no or less than 90 days for this subgroup analysis. So let's go through the results. So we identified total of 5,898 patients in total. And after excluding the 444 patients according to our exclusion criteria, we eventually included 5,454 patients in our cohort, in which 77% of them were non-selective beta blocker users, and 23% of them were non-selective beta blockers non-users. And around 20% of them had already had the first hepatic decompensating events before the recruitment. So this is just a table showing you the baseline clinical characteristics. And because of the time constraint, I'm not going to go through very deeply. Just that the mean age of all the patients in the two groups was around 60 years old, while most of them are male, and most of them had viral cause of cirrhosis. And the group between the users and non-users of the non-selective beta blockers, they have similar severity of cirrhosis by the Chapel class. To look at our first primary outcome first, which is the first or further hepatic decompensating events, the 1, 3, and the 5-year cumulative incidence of the events were respectively 26%, 38%, and 44%. Patients who used non-selective beta blockers had a trend towards a lower risk of developing the first or further hepatic decompensating events. By doing the subgroup analysis, our group actually showed that for patients who had used at least 90 days of non-selective beta blockers, they had a significantly lower rate of hepatic decompensating events than untreated patients. And then those who received non-selective beta blockers of less than 90 days, with the cumulative hazard ratio at 0.88. For the liver-related mortality, the 1, 3, and 5 year of liver-related mortality were 36.1%, 52.8%, and 60.6% respectively. For further analysis, we showed that the use of non-selective beta blockers did not have significant impact on the liver-related mortality. So as if you use the longer duration of non-selective beta blockers, there may be a trend of having a lower rate of liver-related mortality. So because of the time constraint, I'm not going to too deep into the discussion and limitation of my paper. But just to conclude, in our study, we did not demonstrate a significant impact of non-selective beta blockers in reducing liver-related mortality in patients with HCC. But patients with who used patients with HCC who used non-selective beta blockers, there was a trend towards a reduction in first or further decompensating events. And this effect was significant if they used the non-selective beta blockers for at least 90 days. So I think the message behind is that if we want to use the non-selective beta blockers to give a significant impact on reducing the first or further hepatic decompensating events, we may have to consider a continuous use for a longer time instead of frequent interruption due to events, for example, like a low blood pressure, we just interrupt and then we stop it forever. It may need some time for the non-selective beta blockers to exert its effect. So this will be the references that I used, and thank you so much for your attention.
Thank you.
Thank you.
We open to the floor for any questions.
Okay.
Yes, please. If you'd like to just maybe come to the microphone and just share your name and where you are from.
So thank you very much for a very interesting presentation. I have two questions. First of all, you speak of non-selective beta blockers. Did you look at the difference between propranolol and carvedilol, or what were the options in your study? And the second, you talk about a composite endpoint, so all types of decompensations. Do you think there might be a difference there, or just lumping them together might hide an effect? Do you think non-selective beta blockers theoretically protect against all sorts of decompensations? For instance, jaundice in a retrospective study can mean many things. Thank you.
Thank you. Thank you for the fantastic question. So for your first question, we included patients with both propranolol and carvedilol in our study, because in the past 20 years in Hong Kong, they were the most used beta blockers in the public hospitals in Hong Kong. However, we grouped them together for the analysis because the carvedilol users was a much smaller group of patients, mainly because this drug was it was just maybe in the recent years, it was introduced to the use in the public hospitals in Hong Kong. And the second reason for its more number, I think maybe because that it's only very recently there were studies to prove that carvedilol actually has a much better effect than propranolol to prevent the hepatic decompensation, and a much stronger effect in reducing the hepatic venous pressure gradient. And in previously, clinicians or physicians, they actually prefer the use of the older generation propranolol. So that's why we group them together instead of doing the analysis separately, because it makes the results much underpowered. And then for your second question, in our analysis, we group all the hepatic decompensating events together because because of during the analysis, we realized that for some of the decompensating events, for example, the hepatorenal syndrome, it was much less coded in the system. So, which makes the interpretation difficult. But I agree that it may be useful to separate them into small groups to do the analysis to see the beta blockers effect as well. We may do it when it comes to our full paper as well. So thank you so much.
So congratulations on your great presentation.
Thank you.
My question is, do you have the separate the responder and non-responder to beta blocker in your study? For example, do you have the data of heart rate or blood pressure after studying beta blocker of enrolled patients?
Thank you for the question, and it's a very important concept when we use the non-selective beta blockers. I think it's one of the major. I think it's one of the things to consider to include whether the patient is responsive or non-responsive to the non-selective beta blockers. But we didn't do that in our study, mainly because from the it's definitely, I agree that it's a flaw. But first of all, we do not have the measurements of the HVPG, this invasive monitoring in our routine practice. And the other thing is that because from the blood pressure and the heart rate, it is also not available in the CDAS system as well. So the entry is not complete. So we didn't really record, we were unable to retrieve this piece of information fully. So I think a prospective study will be helpful.
Thank you.
Thank you.
Thank you. So thank you for your presentation. So following up from the last question of determining who the responders and non-responders, you have used 90 days as a surrogate for that efficacy rather than compared to no efficacy. Would you postulate what's the biology, or is there any data supporting why a 90 days longer duration effect would make a difference to your portal pressure?
Thank you for your insightful comments. And we actually try to analyze 30 days or 60 days, 90 days, and it comes back to be we found to have a better effect with 90 days, but I don't think there is any study that is very well established on the duration of the use of the non-selective beta blockers in preventing the hepatic decompensation so far, as far as I know.
The second question is on, again, similar to the original question from the floor, looking at the different decompensation or even the cause of death, were you able to determine the relationship between liver-related mortality, non-liver-related mortality, for example, cardiovascular mortality?
Yes, we actually did analyze on the liver-related and non-liver-related mortality, but we didn't really go too deep into the cause of the non-liver-related mortality, just separate into these two groups. But there was no significant effect of the non-selective beta blockers on both liver and non-liver-related mortality.
Right. As you know, there is a little bit of bad press about beta blockers in decompensated cirrhosis when your child, especially child C, blood pressure is low, systemic blood pressure is low. Did you see this J curve in your cohorts, or did you withdraw the child C from your analysis?
We included patients with child Cs as well, but I think it's worth to go back to see the analysis again. But as far as I remember, I don't really see this kind of effect in our study, in our analysis.
Last question on this. So again, this is a group of liver cancer patient. In your first slide, you also mentioned that liver cancer does distort your portal hypertension.
Yes.
Did you have enough numbers in each of these subgroups? Portal vein thrombosis versus no portal vein thrombosis, and therefore were there a difference in a subgroup analysis?
Thank you for this question. So I think for the portal vein thrombosis, it's actually a very important cause of the increase in the portal pressure in this group of patients. But we didn't really, we weren't really able to get a very complete differentiation in patients with or without portal vein thrombosis, mainly because of the coding problem, but because of the in general, actually from the literature, over half of the patient will have portal vein thrombosis if they have HCC. So we didn't really separate them into the groups because of the clinical practice issue on the non-selective beta blockers as well.
Okay. Okay, if there are no further questions, thank you very much for the presentation.
Thank you.
Thank you. Can I check one more time if the first speaker is on site, Dr. Nipun Verma? Okay. Okay, if not, then there will be only two speakers for this particular session. I think we will call this session to a close. The next session will be at 14:10 for the next group of speakers for cirrhosis 2 session. Thank you very much for everyone, and have a good afternoon. Okay. Okay. Good afternoon, everyone. I'd like to open this session. I'm Masanori Atsuka from Nippon Medical School, Japan. I will be chairing this session together with Professor Grace, but she's not in here. The session is Young Investigators Workshop, APASLAASLD, Cirrhosis 2. Today's three presentation will be 10 minutes and each and 10 minutes for discussion. The first presenter, was it? Okay. I'd like to introduce Fazit. The first speaker is Dr. Wazit from Thailand. The title of his presentation is Sarcopenia is associated with the risk of minimal hepatic encephalopathy in patients with cirrhosis. So let's get started with your presentation.
Good afternoon, ladies and gentlemen. On behalf of all authors, I'm so honored to present my research as APASL 2024. We have nothing to declare for this study. Sarcopenia is a condition characterized by a reduction in muscle mass and either muscle strength or physical performance. Sarcopenia has gained significance in the evaluation of patients with liver disease. The prevalence of sarcopenia is approximately 30 to 50% in cirrhotic patients. Sarcopenia is found to have a detrimental impact on clinical outcomes in patients with cirrhosis, such as higher mortality and risk of overt hepatic encephalopathy or OHE. Minimal hepatic encephalopathy or MHE is a subtype of hepatic encephalopathy associated with subtle cognitive deficits, such as reduced attention and integrative functions. Prevalence of MHE is about 20 to 25% in cirrhotic patients. MHE negatively influences quality of life and driving skill. It's also associated with higher risk of hepatic decompensation and mortality of cirrhotic patients. It is proposed that reduced muscle mass in sarcopenia may cause reduction of glutamine synthetase activity and lead to accumulation of ammonia level. Hyperammonemia disrupted function of astrocytes and resulted in the development of overt hepatic encephalopathy. However, whether sarcopenia contributes to development of minimal hepatic encephalopathy remains unknown. Therefore, these prospective studies aim to investigate the association between sarcopenia and MHE in Thai patients with cirrhosis. We prospectively enroll adult patients with cirrhosis between April to October 2023 at Liver Clinic in Sirat Hospital, Thailand. We recruited patients without clinical manifestation of OHE according to West Haven criteria. To confirm the absence of OHE, we examined the patient with the mini mental state examination or MMSE. Patients with MMSE score of at least 24 were confirmed to not have OHE and included in our study. Patients with conditions that could influence sarcopenia or MHE are excluded. Exclusion criteria as in display. The example of exclusion criteria are patients with neuropsychiatric conditions such as Parkinson's disease and Alzheimer's disease, patients taking psychoactive medications such as benzodiazepine, patients currently taking lactulose rifaximin, or BCAA. Patients with uncontrollable decompensated comorbidities, such as heart failure with NYHA class 3 to 4, end-stage renal disease, and COPD Gold D. All patients were evaluated for detailed clinical and biochemical data for severity of liver disease. Subjects were tested with the validated Thai version of paper pencil-based psychometric hepatic encephalopathy, or PHES, to determine their cognitive functions. PHES is considered a gold standard for diagnosis of MHE. PHES is composed of 5 tests: the number connection test, NCT A and B, the digit symbol test, DST, the serial dotting test, SDT, and the line tracing test, LTT. The score of each test ranged from -3 to +1. The score was graded based on the validated normative values, adjusted for age and educational levels for Thai population. The total score of PHES ranged from -15 to +5. Patients with PHES score of less than -4 were diagnosed with MHE. All patients were tested according to standardized manual instruction. All patients were evaluated for the presence and severity of sarcopenia according to the 2019 criteria by the Asian Working Group for Sarcopenia. Muscle mass is measured with bioelectrical impedance analysis, or BIA, to measure skeletal muscle index, or SMI. SMI is determined by appendicular muscle mass divided by height square. Low muscle mass is defined as SMI less than 7 in men and less than 5.7 in women. Low physical performance is defined as gait speed from 6-meter walk less than 1 meter per second. Low physical strength is defined as hand grip strength, measured by hand grip dynamometry of dominant hands, average for 3 times, less than 20 kg for men, and less than 18 kg for women. Sarcopenia is defined as low muscle mass with either low physical performance or low muscle strength. Serious sarcopenia is defined as low muscle mass with both low physical performance and low muscle strength. We computed odds ratio with 95% confidence interval in unit rate logistic regression analysis. Factors with p-value less than 0.1 in unit rate regression analysis were included in multivariate logistic regression analysis. P-value less than 0.05 was considered statistically significant. 220 cirrhotic patients were screened for MHE. 10 participants were further excluded due to MMSE score less than 24. Remaining 210 patients participated in this study. 57% patients were male. The mean age was 62 years old. 195 patients in child Pew A and 15 patients in child Pew B. The mean male score was 9. Most common etiology of cirrhosis in our study was viral hepatitis. The prevalence of MHE is 17.6%, with prevalence of 16.3% in patients with child Pew A and 33.3% in patients with child Pew B. The prevalence of sarcopenia is 25.7%. The prevalence of serious sarcopenia is 12.3%. MHE group usually had more advanced age and lower education level. Most patients in MHE group had primary school education. They also had higher prevalence of history of hepatic decompensation, such as history of overt hepatic encephalopathy and variceal bleeding. There is no difference in etiology of cirrhosis between two groups. Patients with MHE were more likely to have more severe liver disease index, such as higher total bilirubin, lower albumin, higher globulin, lower platelet, and lower leukocyte. There is no difference in MELD score and Child-Pugh classification between two groups. Moreover, Patients with MHE tended to have higher proportion of sarcopenia and severe sarcopenia, reduced muscle mass, lower muscle strength, and physical performance, as reflected by lower skeletal muscle index and hand grip strength and gait speed. Patients with sarcopenia had lower total score of PHES and in all subdomains of PHES, implying worse cognitive functions in sarcopenic group. In univariate regression analysis, MHE was associated with age, education at primary school, sarcopenia, and history of variceal bleeding. In multivariate regression analysis, adjusting for factors with p-value less than 0.1 in univariate analysis show that only age, sarcopenia, and history of OHE and variceal bleeding were associated with presence of MHE. When we substituted severe sarcopenia instead of sarcopenia in both univariate and multivariate analysis, we found that severe sarcopenia was independently associated with MHE, with adjusted odds ratio of 3.64, with 95% confidence interval between 1.32 and 10.05. In conclusion, sarcopenia and MHE are not uncommon among patients with compensated cirrhosis. Sarcopenia and severe sarcopenia are independent risk factors for MHE, regardless of cirrhotic severity. Detection of sarcopenia might help identification of MHE. Intervention for sarcopenia such as nutritional improvement might lead to better quality of life in cirrhotic patients. Thank you.
Thank you for your great presentation, Dr. Wazit. So floor is now open for discussion. Are there any questions? Please.
Thank you for your great presentation. I really enjoyed it. I have a question that, have you done any research on the reverse? I mean, if sarcopenia improves, does minimal hepatic encephalopathy improve or something like that? If sarcopenia improves, does MHE get better or not?
It is a very interesting question. Actually, I think we might need further research about that topic because in my literature review, there's no such data in that topic that if we improve sarcopenia, the MHE will get better. But I agree with you that such intervention to improve the sarcopenia will help improvement of the cognitive function of cirrhosis patient because if we go back to the background of this study, if the muscle mass is reduced, the way to reduce the way to get rid of the ammonia in our body is reduced. So if we can improve the muscle mass, the way to get rid of the ammonia will get better, and so the cognitive function might get better.
Thank you. I'll be looking forward to hearing from you.
Thank you. Any other question? Okay. You report the association between MHE and sarcopenia in patients with cirrhosis and mentioned MHE is more common in elderly patients with cirrhosis. So is it possible to that dementia is also excluded from this patient?
Yes, this is one of the strengths of our study because neuropsychiatric conditions such as the dementia, Alzheimer, and Parkinson are totally excluded in our study, and we confirm the exclusion of that condition by the mini mental statement examination, the tools that we use to diagnose the dementia. So in this study, we can confirm that dementia is totally excluded because MMSE score of all patients in our study exceeds 24.
Okay.
And exclude the diagnosis of dementia.
Okay, thank you. Please.
Sorry, just another quick question. Asim from Auckland City Hospital, New Zealand. Congratulations on the great presentation and great research. So in your two groups, it looked like there was a clear difference in the people who had demonstrable portal hypertension in the past with either overt encephalopathy or variceal hemorrhage. Any thoughts on the role of that as a common mediator for both sarcopenia and MHE?
Actually, I think the portal hypertension directly related the severity of liver disease. For example, if we have more severe liver disease, like more stiffness of the liver, it is harder to for the liver to detoxify for detoxification of like bad stuff in our body. So it's reflected in more history of portal related complications such as variceal bleeding and hepatic encephalopathy. And when we look at the liver disease index, patients with MHE tended to have a lower number of platelet counts, which directly correlated with portal hypertension.
Right. Yeah.
So I think actually like portal hypertension can be a main explanation also for the development of MHE.
Yeah. Cool. Thank you.
Besides sarcopenia.
Thank you for the very interesting presentation. So normally the gold standard for skeletal mass index is done in MRI, body composition, or DEXA scan. Do you have a chance to validate your machines to show that it gives you reproducible readouts?
Actually, for the Asian population, the gold standard for sarcopenia diagnosis can be DEXA scan or CT scan, but due to limited availability of like sarcopenia L3 muscle index, it is proposed that for general population or for cirrhosis patient, BIA bioelectrical impedance can be substitute to diagnose sarcopenia, and in this study we use the BIA for the detection of muscle mass because not all patients with cirrhosis undergo CT scan. Some patients got a screening SCC by the ultrasound, so I think in this study it's more applicable to real practice to diagnose the sarcopenia because like it is much easier to diagnose the sarcopenia in cirrhosis, no need to further imaging. And actually we have the result from the study in Thailand from Songkran Nakrin Hospital. It's proved that hand grip strength and BIA actually directly correlated with the gold standard of sarcopenia with L3 result from CT scan. AURC is very high. It's about 90 to 95% for the detection of sarcopenia.
Right. Yeah. Second question is, were you able to correlate with the serum ammonia with MHE?
Yeah, this is actually when we at the concept of the study, we would like to collect the ammonia level. But as we all know that collection of ammonia is very difficult because we have to collect the ammonia from arterial blood collection, which can be very distressed and painful experience for all patients. And it's also very difficult to transport to the laboratory, and also ammonia level, if not handled appropriately, the level can be influenced by very several factors. So
last question, a bit complex, but so you have shown a association between sarcopenia and MHE. How do you do the next experiment to find out which direction does it go? Is it sarcopenia causing MHE, or is it MHE and therefore they don't eat as well and therefore they result sarcopenia?
This is thank you for your question. This is the main limitation of our study, because our study is conducted in cross-sectional study, so we cannot firmly establish the causal association between two conditions, whether what comes first. But we plan to further conduct this study. That, for example, we plan to conduct the study that we will bring the patient that we screen at this time do not have the MHE at this time, and we will follow the patient maybe like for a year, and we will perform the PSES again to detect whether they develop MHE in kind of like a cohort study. So we can further establish the causal relationship between two conditions. But in this study, I think sarcopenia can cause a causal relationship to MHE due to like possible biology possibility.
Okay. Any other question? Okay, last question. You excluded the patient using rifaximin and BCAA, and my question is, were there any effect on drugs on complication with cirrhosis in this study? For example, it has been reported that loop diuretics worsen sarcopenia. Diuretics?
We do not exclude the use of diuretic in this study. The reason we exclude the use of rifaximin, BCAA, and lactulose in this study because these three agents are proved to improve the overt hepatic encephalopathy. So we believe that the use of these three medications can influence the cognitive function of patient with cirrhosis. So we try to get rid of as many as confounding as possible.
Okay, thank you. Okay. Thank you, Dr. Wajid.
Thank you.
And the second speaker is Charlotte from China. Charlotte. The title of her presentation is Risk Factors of Liver-Related Event in Patient with Type 2 DM. Let's get started with your presentation.
Okay, thanks, moderators, for a kind introduction. And good afternoon, dear professors, doctors, dear colleagues and friends, dear ladies and gentlemen. I'm Charlotte Juan Song, a second-year PhD student from the Chinese University of Hong Kong. And it is my great pleasure to be here in the Young Investigator Workshop today and to share with you something about our project on risk factors of liver-related events in patients with type 2 diabetes mellitus. First, I would like to declare this study was supported by Health and Medical Research Fund of Healthy Bureau of HKSAR government. In recent years, we have all seen the rising prevalence of the non-alcoholic fatty liver disease, NAFLD or MASLD, as well as the advanced fibrosis and cirrhosis among patients with type 2 diabetes mellitus. Apart from the prevalence of metabolic syndrome, other common risk factors, including alcohol use, obesity, also play an important role in the development of liver-related events. Meanwhile, recent years have also seen the increasing trend of youth onset of type 2 DM, along with the rising prevalence of obesity and the involving strategies for the management of type 2 DM. All of these have made the interplay between the type 2 DM and adverse liver events more complex. So to elucidate the association between diabetes and liver-related burden, as well as to prioritize the screening for those at higher risk for liver disease among patients with diabetes, we performed this study with three main purposes. Well, the first was to estimate the secular trend of liver-related events disease burden among patients with type 2 DM. And the second, which is also the focus of my presentation today, was to identify risk factors associated with the risk of liver-related events, LRE. And the next step involves developing a lasso-based prediction model for the screening purposes. Initially, we included all adult patients with the diagnosis of type 2 diabetes mellitus from the January 2007 to December 2021 in Hong Kong. And after exclusion of those with chronic virus hepatitis, excessive alcohol use, metabolic and autoimmune liver disease, as well as those developed malignancy or liver-related events between their diagnosis of type 2 DM, we included 575,000 patients in our final cohort. Well, the primary endpoint was set at the incident liver-related complications within the follow-up duration. And the liver-related complications definitions include hepatic decomposition, HCC, liver transplantation, and liver-related death. Well, the secondary endpoint included the non-liver-related mortality within the follow-up duration. From the flowchart in the slides, we can say that our patients at a median follow-up duration of 6.2 years were diagnosed at the mean age of 61.9 years old, with 52.3% being males. And the incidence rate of the liver-related events was 1.279 cases per 1,000 person-years at risk. We then perform univariable and multivariable regression analysis to investigate the association between the diabetes and liver-related events, as well as to do the variable selection for our next step, predictive model construction. And we also do the population attributable fraction analysis to better understand the risk estimated by each factors. So based on the primary analysis from the univariable fine-grained competing results regression model, we found that the advanced age, male gender, presence of compensated cirrhosis, hypertension, as well as baseline use of sulfonylureas and insulin were all associated with an increased risk of liver-related events. However, some of the non-significant variables in the univariable analysis turned out to be significantly associated with the risk of liver-related events by multivariable cause-specific competing analysis. For instance, higher body mass index was actually associated with increased risk of liver-related events, while the effect of insulin on liver-related events were reversed with a less than 1 subdistribution hazard ratio. And this impact and this seemingly protective effect of insulin on LRE can be actually largely attributable to the survival bias. That is, the patients receiving insulin therapy initially may have poor glucose control and may be more likely to experience non-liver-related mortality earlier. So this may, and this is also reflected by their greater than 1 subdistribution hazard ratio of insulin for competing death analysis. So this is the reason why the manifestation of liver-related events were hindered. Oh, sorry. And all these results have provided some insights for the management of patients with type 2 DM. And those with diabetes and cirrhosis, even still in the compensated stage, still need heightened clinical attention and closer monitoring on their liver function. Additionally, we also observed a nonlinear association between hemoglobin A1C and the risk of liver disease. And based on this U-shaped curve from the restricted cubic spline analysis, we found that the hemoglobin A1C contributed to the liver-related risks much more significantly for extreme levels when the hemoglobin A1C were distributed at 2 ends, compared to the relatively normal range of the parameter in the middle of the curve. And that's also provides some considerations for the management of type 2 DM, indicating that we should not only focus on those with poorly controlled high blood sugar, but also need to exercise extra caution on those who are prone to hypoglycemia, since the hypoglycemic condition may also pose hidden hazards to the patient's liver function and health. Finally, we also performed the population attributable fraction analysis for liver-related events and non-liver-related mortality. And among all covariates, you can find the advanced age explain most about the incidence of both liver-related events and non-liver-related mortality, followed by the compensated cirrhosis in the liver-related mortality, but calcium channel blocker use for non-liver-related mortality. However, compensated cirrhosis still contributed to about 5.2% risk of non-liver-related death in type 2 DM. This finding also highlights the importance of the complex interplay between the diabetes and liver. And this finding suggests that those with the coexistence of the two conditions, these patients may significantly increase the risk of higher subsequent poor prognosis, whether from liver-related or non-liver-related complications. And this is also in accordance with most previous findings that cardiovascular events remain the top cause for the mortality among patients with NAFLD. So ladies and gentlemen, please allow me to emphasize the importance of the following points again. Advanced age, male gender, presence of compensated cirrhosis, higher BMI, increased creatinine and baseline use of sulfonylureas were all associated with increased risk of liver-related events among patients with type 2 DM. And a nonlinear association between the hemoglobin A1C and the LRE was observed. Advanced age was the most important risk factor for development of liver-related events, and the compensated cirrhosis significantly contributes to liver-related events, and to a lesser extent to non-liver-related mortality. Our recent work updates involves passing the variable lactate by multivariable analysis to the lasso regression methods to build a more refined and predictive model for validation. And thanks again for your presence and listening to my talk here, and any comments and advice will be greatly appreciated. Thank you.
Thank you for your excellent presentation, Dr. Charlotte. Are there any questions?
Congratulations on your great presentation. I'm Dr. Praksa from Chulalongkorn University, Thailand. So I have two questions. The first one, there's more data that for patients with MAFLD and have F2 or significant fibrosis is related with mortalities. So do you have the data about significant fibrosis or any non-invasive tests that show relations with survival in patients with type 2 DM? And the second question is pioglitazone and like GLP-1 agonist is a treatment of choice and have many studies in patients with fatty liver. So do you have the data specified to this medication? Thank you.
Okay, sorry for your first question. Can you please repeat it? I didn't catch it very clearly.
Okay, so do you have the like non-invasive test or TE or fibrosis score that show about like significant fibrosis related to mortalities or survival in patients with type 2 DM from your study?
Okay, we do calculate the non-invasive fibrosis of FIB4 and APRI for the I got the initial inference model, but we didn't associate its relationship with the mortality, since we consider that many parameters included in our study will have certain missing, and because this is such large cohort, and we use some single imputation to compensate for that. And after that, we think the FIB4 and APRI based on that may not accurately reflect the liver function or status of our patients at baseline. So we just use them for the observative purpose. Thank you.
The second question is, some medication used to treat fatty liver, for example, pioglitazone or GLP-1 agonist. Do you have data about that medication?
Yes, we do. We do include other categories of anti-diabetic medication, but after multivariable analysis, some anti-diabetic medications may be due to the relatively limited usage within our cohort. They were proved to be non-significant, and I already put all significant variables with the outcome of interest in the slides, so others may be non-significantly. Thank you.
Any other question? Okay, please.
Thank you for your presentation. I was very intrigued with the HbA1c J curve. So the idea that low HbA1c is also detrimental, was there evidence of hypoglycemia and so on to support the biology why patients were doing badly with low HbA1c?
Sorry, may I confirm that you asked the reason for the low hemoglobin A1C?
Yes, right.
Contribute to the risk? Or, okay, I think we have discussed about that point, and that is a very important question. I think the main reason why the low hemoglobin A1C associated with the significant higher liver-related events is due to their overall bad condition, because when the blood glucose was lower than the normal range, like before 5 or 4, the patient's overall body condition is not so good, and that's can be associated with significantly not only liver-related mortality, but also other non-liver-related events, like cardiovascular events or the higher mortality, etc. So I think that's that is mainly due to the status. The patient status was not so well in that case. Thank you.
The second question is on the finding of compensated cirrhosis as one of the predictor. How was this established by ultrasound for our patients, or do they receive a protocol fibroscan for the clinical practice?
You mean our definition for the compensated cirrhosis?
Yeah.
We mainly define the compensated cirrhosis with the diagnosis codes. We adopt the SAD9 code from our electronic patient health system to differentiate those with the liver-related symptoms of different severity.
Right. Last question on the Lasso analysis, where you list put the factors together. Is this translatable into a clinical score that can be used to predict high-risk patients?
We have been considering that, but we are not very certain about the practical value of the risk score developed. As you can see, there are many risk scores nowadays, and if we can truly apply that into the clinical practice, it remains a question. But we do build such model, and I would like to see its discrimination and calibration value to be optimal enough, and to determine such an optimal model, and then to consider next step of the practical risk score application. Thanks for the question.
Okay, please.
Thank you for your informative speech, Leita Shakian from Armenia. You discussed about the relationship of liver cirrhosis and type 2 DM. And what about the treatment options? How you think when we improving the liver's function, it is possible to include the type 2 DP treatment option this care?
Yes, you mean the treatment of the anti-diabetic drugs can have a certain...
And including the, for example, hepatoprotective drugs in these diseases or treatment options, for example. How do you think about that?
Yes, may I confirm that you mean the use of anti-diabetic medication may generate some bias on the relationship reflected by the analysis? Yes, that's an important question, and we also consider the potential impact on the anti-diabetic medication. But for instance, our next step of Lasso prediction model construction, we just remove those anti-diabetic medication, because we think the medication use will depend on many factors we cannot control. Like it can largely dependent on doctors' subjective opinion and also the patient's conditions development. So for the prediction purpose, we exclude those medication impact. But for now, it's just a multivariable analysis, and we would like to observe and to investigate the concrete risk factors associated with that specific liver-related events. So we would like to include them, but we also to perform the additional analysis like time-dependent analysis, which also consider the time of the anti-diabetic medication use into the analysis and to model the change of the medication as well as to analyze their impact on the liver-related events. So the time-dependent, according to the time-dependent analysis, we also have some novel findings like the insulin impact, as I mentioned just now. Its effect on the liver-related events was reversed again, and just over the one again. And we guess the time-dependent analysis can more objectively reflect the anti-diabetic medication impact. But for prediction, we just remove them.
Thank you.
Thank you for question.
Thank you. May I ask a last question?
Okay, thank you.
According to your presentation, liver-related events were defined as both the development of HCC and decompensation, right?
Yes.
Okay,
Both was defined as the primary outcome.
So my question is, what factors were associated with development of HCC?
Oh yeah, thanks for your question. That's an important point because I also found some study. They will investigate the risk factors associated with HCC alone. But I'm regret to say that our project only combine those as a composite endpoint of both liver-related events and HCC, and to define them as our primary outcome and to observe this development. But we do think this has it has certain value since many liver-related events as long as it's severe enough may have a large likelihood to develop into the HCC. Yeah, but currently we have not do the separate analysis for this subgroup, but we may consider it for our.
Okay, thank you. Okay, any other question? Okay, thank you, Dr. Charlotte.
Okay, thank you again.
So I'd like to introduce last speaker. The last presenter is Andrei from Romania. The title of his presentation is a prospective study of cardiohemodynamic profile change in acutely decompensated cirrhosis and ACLF. So let's get started with your presentation.
Thank you very much for the opportunity of presenting our results to you here in this competitive workshop and in the beautiful city of Kyoto. These are my disclosures. Now, I'm going to repeat this several times throughout the presentation. This was an exploratory cohort study, so of course we started with things that we did know, tried to find out things that we did not know, but along the way also found out there were things we didn't even know we didn't know. So let's start with what we did know. We know that cirrhosis isn't just a single organ failure, it is a multi-system syndrome. We know that it does affect the heart, that cardiac dysfunction is prevalent in cirrhosis, up to 40% in stable patients. There is even an entity that has been termed cirrhotic cardiomyopathy, which is defined by echocardiographic evidence of systolic and/or diastolic dysfunctions in the absence of known heart disease. We know that acute on chronic liver failure is highly dynamic, that it is driven by inflammation, and that it includes a circulatory component, which is, of course, the mean arterial pressure. And recently, it has been shown that hyperdynamic cardiac patients with cirrhosis are at highest risk for fatal ACLF during short and long-term follow-up. So our group has previously looked at associations between imaging parameters of heart failure, mainly echocardiography, but also MRI. And we have seen that there are associations between these factors and conjugated bile acid levels in stable patients with cirrhosis. that there are indeed associations with markers of fibrosis and inflammatory markers, this in relationship to the extracellular volume determined by MRI in patients with cirrhosis. And recently, in a retrospective cohort, we have also found out, surprisingly to us, that patients with cardiac dysfunction defined by echocardiography were actually less likely to die during long-term follow-up, which of course prompted us to consider the questions of what we still do not know. And we still do not know the real prevalence of pure cardiac dysfunction in patients with cirrhosis. We do not know to which extent circulatory dysfunction in acute decompensation of cirrhosis can be attributed to latent heart failure. And unfortunately, there are still questions around the reliable diagnosis of cirrhotic cardiomyopathy. Even though the criteria for diagnosis have recently changed, this is mainly an echocardiographer's game and not a hepatologist's game. So our hypothesis moving forward was that there were links between inflammation, circulation, and the development of ACLF in patients with cirrhosis. We also suspected that the highly dynamic changes seen early on after diagnosis of ACLF could partly be due to rapid changes in the cardiocirculatory system, and consequently expected to find associations between CLIF-C scores, inflammatory markers, echocardiographic parameters, and ultimately patient outcome. So our aims were to explore the cardiocirculatory profile of these patients admitted for acutely decompensated cirrhosis, to investigate any associations between serologic biomarkers and echocardiographic parameters, and to identify cardiocirculatory prognostic markers of negative outcome. And this was our study design. This was again an exploratory prospective cohort study, a single center study that included patients with acute decompensating events and excluded those with history of heart disease or those that we identified with concurrent diseases such as atrial fibrillation. And our outcomes were hard endpoints, 1 and 3 month mortality. And basically, after the screening, the first visit included, of course, the clinical work, blood work, CLIF-C scores. We took serum samples for biomarkers, and we performed an echocardiography within 24 hours. The second visit took place 5 to 7 days later, and we repeated the same protocol. We had another visit at 1 month and a telephonic follow-up visit at 90 days. So this was our cohort. In the end, for this analysis, we looked at 66 patients with a 59 years mean age. The etiology was mostly alcohol-related cirrhosis. The main type of acute decompensating event was ascites, but of course these were not mutually excluding. 41% of patients had a previous decompensation within the past 3 months. This was the mean MELD score and the child class distribution. Only 9 out of those 66 patients fulfilled the criteria for ACLF with a median score of 46. So this is a table looking at some of the most relevant biologic parameters at day 0, day 5, 7, and at 1 month. And I'll just briefly draw your attention to the mean arterial blood pressure here. Also to the fact that, surprisingly for us, echocardiography speaking, systolic and diastolic dysfunction were present in very few patients, actually. If you remember, we spoke about up to 40% in stable patients, but we saw a lot less than that in this cohort. No patients with ACLF on admission fulfilled the criteria for cirrhotic cardiomyopathy. And then there was a change in mean arterial pressure from the day 0 to up to 1 week. And we tested this in a paired sample t-test, and it also turned out relevant. So the mean arterial blood pressure goes down in the first week after the admission for decompensating events. Looking at the hard outcomes, we saw that 12% of patients died before 1 month and 24% before the 3 months follow-up. In univariate analysis, death was associated with a decreased mean arterial blood pressure at admission, which was not surprising, with an increased pro-BNP level, which is a marker for heart failure, and with some echocardiographic parameters of left ventricular diastolic dysfunction, another indicative of heart failure. But looking at, so this is the OROC curve, which seems pretty good, but looking at the multivariable analysis, and of course this is questionable because we have very few events, but we did this anyway in different models. We saw that mean arterial blood pressure does hold up, and it is the only one that does hold up as a predictor of death during follow-up. As I've said, this was exploratory, so we've also looked at some associations just to guide our way forward, and we did see some negative correlations between mean arterial blood pressure, NT-proBNP, which of course makes sense, and severity scores for cirrhosis. We saw some negative correlations between left ventricular ejection fraction and left atrial volume index, which are again parameters of heart failure, and some correlations between pro-BNP levels and inflammatory markers such as CRP and IL-6. So our limitations are pretty obvious. This was a partial analysis. We still have some pending results for other biomarkers. We had few patients with ACLF in the cohort, so obviously this is not applicable to that particular population. There are the limitations of echocardiography in practice in patients who have large volume ascites, and it is very difficult to always get reliable results, and I'm going to come back to that. And there is a statistical risk here, of course, because this is exploratory in nature. We have multiple hypothesis testing problem and the risk of type 1 error. But our conclusion, nonetheless, was that the prevalence of cirrhotic cardiomyopathy was much lower than expected for sicker patients with acute decompensating events. There are signals that inflammation associates with cardiocirculatory dysfunction, and that mean arterial blood pressure and some echocardiographic parameters of diastolic dysfunction do seem to predict short-term mortality. So our questions after this study are all decompensating events the same for the heart, for the cardiocirculatory system? And we believe the answer is no. Is it perhaps time to move away from echocardiography as the single gold standard modality for diagnosing cirrhotic cardiomyopathy? And we believe the answer to this may be yes. And furthermore, in such studies, we really do see the potential for deep learning in defining clinical entities such as cirrhotic cardiomyopathy. So this was a very recent study that looked at ECG from many patients and has shown that deep learning can indeed identify the existence of cirrhosis based on the ECG of a patient. So this is very exciting moving forward. With that, I thank you for your attention. Gozeichu arigatou gozaimashita.
Thank you for a great presentation, Dr. Andre. Are there any questions? Please.
Very interesting presentation. Could I check in your cohort of patients, did you do a baseline echo to assess whether there was cardiomyopathy before they go into decompensation? And was there dynamic changes with the decompensation?
Thank you. That's an excellent question. So basically, we know a lot of the definition of cirrhotic cardiomyopathy is actually based on stable patients. So what we try to do for the first time, as far as we knew, is look at this definition in the acute setting, patients with acute decompensation. So we started from the baseline, from admission, and that's when we performed the first echocardiography. Of course, we don't have prior echocardiographies from pre-decompensating times for these patients, so we can't actually assess the prevalence. This is one of the points of the study, that perhaps the echocardiography is not necessarily the best way to diagnose this condition. And there's actually been a study that's published, and I think it's going to be presented here as well, looking at patients with sepsis, with circulatory failure, that defined cirrhotic cardiomyopathy in that group of very much sicker patients than the ones in this cohort. And it would be interesting to ask the presenter why they thought that the definition of cirrhotic cardiomyopathy could apply to patients that came with severe sepsis and obvious circulatory failure.
So indeed, related to your answers, one of the concerns when a patient is decompensated, there's a sepsis on board, there is cytokines and so on, so the circulatory disruption is down. How do you control for a steady state for you to do that assessment? Were the patients not septic, or did you exclude components like this which may confound your analysis?
So again, that's a very good point. One of the ways in which we tried to do this was to have an echocardiography done at 1 month after the event, when the patients who survived were stable. So we do have a sort of comparison after the fact for those patients. So that was one of the ways in which we can do that. And we are currently moving forward with an extension of the study, looking at stable patients without prior decompensating events and trying to follow them up longitudinally and see how that echocardiography changes, if it does.
Okay, any other question? Okay. May I ask a question? Does the decreasing mean blood pressure reflect the effective circulating plasma volume in these patients?
It's a very good question, and it's a very complex question to answer properly with what we had. So we do notice this decrease in blood pressure after 1 week after the admission, and it may be due to reduced plasma volume. These patients, of course, received standard care, so that might involve fluid shifts from extracellular space, so that is a possibility, and we try to look at that as a confounder.
Okay, thank you.
Thank you.
How about CV? Okay. Okay, any other question? Okay, thank you, Dr. Andre. So I'd like to close this session. I'm excited to chat with them about our topic today. And thank you for coming to Kyoto today. Thank you.
Okay. Okay, good afternoon, ladies and gentlemen. My name is Norio Yamashiki from Kansai Medical University. I will chair the last session in this room, the young investigator workshop on cirrhosis. It looks a very core member of the APAS. So please relax and we will contact very face-to-face and make this session fruitful. Okay, the first speaker, please, prepare please. First talk is on morphofunctional restoration of the hepatopulmonary axis in the early stage of liver cirrhosis, presented by Dr. Lilith Arshakyan.
Yeah.
Okay, from Armenia. Please start.
Thank you to the opportunity being here and meeting these knowledgeable people. I have something to say. Let me introduce my research work about the hepatopulmonary axis and early stage of liver cirrhosis. I explained the Scientific Technological Center of Pharmaceutical and Organic Chemistry, National Academy of Science, Republic of Armenia. So we have nothing to declare to this study. Then when we talk about the liver, main people think about the digestion, but we know, all of us know that the liver has more functions, more than 1,000 functions, which are only a small part include the pathological studies. And we know that the main important capacity of the liver is the regeneration. When the regeneration options are disturbed, the liver can be decreasing their disease options, and the final stage of all of the liver failure is the liver cirrhosis. And in my opinion, the healthy liver is the guarantee of our healthy life, and this is possible to lead a healthy lifestyle too. And the second important the guarantee of the metabolic homeostasis is the dynamic capability of the liver's morphofunctional integrity, which depends on the regeneration functions in the hepatocytes. And as a final stage, liver cirrhosis can added the many toxins. It will be an exogenous and endogenous toxins, and we know that the liver have more complications and have a lot of causes. So it is important to investigate the other changed organ morphofunctional integrity during the liver cirrhosis development, because the results show that the number of deaths from the cirrhosis is projected to increasing in next decade. So in my opinion, it's because the more comparative studies for the pathogenesis of liver cirrhosis are not developed yet. So development of new strategies for investigating of complication symptoms of liver cirrhosis development can be possible to evaluate on the finding the more effective preventative and protective options of the treatment these diseases. So the hypothesis is find the causal consecutive link between liver cirrhosis through assessment of the morphofunctional features of other changed organ system, considering organism as one whole. This is the big idea, and today I only talk about the objectives this research worked, but we know that pulmonary complications are very important part for the patient's quality of life in liver cirrhosis, and we have a goal to study the spectrum of hepatopulmonary complication and early stage of liver cirrhosis development with personalized analysis. And we know that nowadays using the herbal medicine for treatment of any diseases are more relevant because the other drugs can have many side effects and can lead to pathological symptoms, other organs, and we are to go the next main objection to evaluate the liver cirrhosis development options with new our suggestion, flamine celemarin mixtures with herbanologine, and using the point of our new approaches for early stage investigation of liver cirrhosis. And about the methods, observatives, analyticals, and comprehensive study using this research work. And about the analytical methods, show the slides. And when you have a question, I would like to answer these questions. And about the results, when in early stage of liver cirrhosis, in the morphological study, the same anatomical observation in the liver, lungs, and other organs can be different of the histological and biochemical study. And we show that in early stage of liver cirrhosis development, lung tissue of males are more stricken than females. So it is important part, and I think that it is be used in the methods of medicine to create the more comprehensive approaches. And in the serum proteins analysis, we show the same facts that in albumin globulin ratio, which are gold standard for the studying of liver cirrhosis, in male animals, increasing more than in female animals in early stage of liver cirrhosis. It is due the fact that the genders is important for using the treatment and analytical options for this disease. And about the features of nuclearity of hepatocytes, according to gender, we show that in females, animals are more the total B nuclear hepatocytes. It is show that fact that the regeneration function in the females are more intensified. So it is due that in females will be delayed the cirrhosis development. And the next, for morphofunctional restoration of the hepatopulmonary axis with our suggest flamine celemarin mixtures, we show the body changes and the liver index in the disease and treated animals, and we see that in the treatment animals, nothing morphological disorders show, and the related body weight is increasing as in control group. It shows the effectiveness of our suggest medicine in the treatment options of excuse me. Thank you. And don't change. This slide not don't show. Okay. I can discard in final slide, so it's okay. And morphofunctional restoration of this suggested mixture shown in the histopathological analysis too, and we see the morphological restoration of the livers and lungs are succeed in adding this, yes, treating these mixtures, and the same analytical study showing the albumin globulin ratio that after treatment, the restoration of the albumin globulin ratio are increasing and go up to the healthy animals ratio. And to be conclude, I would like to say that pre-symptoms of liver cirrhosis are clearly observed in the anatomical and histological features during the initial stage of cirrhosis. Lung lesions are more severe, more often in males. And those in the acute or subacute cirrhosis development, hormonal features as well as behavioral and emotional traits are critical in defining the hepatopulmonary axis differential diagnosis. And the final, our new suggest combination medicine, flamine-celemarin, has a preventative and protective effect at the lung-liver morphofunctional axis in the pre-cirrhotic stage. So to sum up, I would like to say that treating organism as one whole, in the dynamic of the liver cirrhosis development, we can find the new symptoms in the chains of other organ systems in the liver cirrhosis development. And thank you for my laboratory teams. We helped me to do experimental models in the animals, and great thanks to Dr. Sargsyan. Without his kind direction and proper guidance of this study would have been a little success. Thank you for your consultation. I would like to ask her your questions.
Any questions from the floor? First, yes.
Thank you very much. It's very, very interesting findings. I'm Yasuko Iwakari from Yale University. So what is the potential mechanism of this herbs affect to or ameliorate or restore the structural functional features of hepatopulmonary syndrome or lung structure in cirrhosis?
About the mixture?
Mixture or even
about
like
this
each of
medicine
them,
which
or
I use,
mechanism,
yeah?
mode of action of those drugs.
Yeah, in the literature data shown about the celemarin, which is the flavonolignan mixtures of the Silybum marianum seeds. Our collaborators take me this celemarin and flamine, and the mixtures I prepared too. And this is have a more effectiveness in the anti-inflammatory effects, hepatoprotective effects too, and antifibrotic effects. And about the flamine, we use only Armenian species of the Helichrysum rubicundum. It is the new project because these herbs don't use for the flamine. And flamine have another species, antibacterial and cholangiol. So we are we think that mixing and protective all liver functions to prevent, not treat the disease.
Okay.
This is the main goal.
Okay, thank you.
Thank you so much for your question.
Yes, please.
Okay. Thank you for your presentation. How did you determine the ratio of flamine and celemarin?
Thank you for interesting question. Excuse me. Because the celemarine are the more hepatoprotective activity, we suggested higher for 1-2 ratio. But next we will study other ratios too, and finding the more effective ratio. It is our next plans. Thank you.
As you said in your study, you want to study the hepatopulmonary syndrome. But as we know that hepatopulmonary syndrome and liver cirrhosis, the disease one is the liver, not the lung. So, but you use carbon tetrachloride animal models as animal models, and we know that carbon tetrachloride not only can make damage in the liver, produce the cirrhosis, but also can make fibrosis. So fibrosis of the lung. Fibrosis of the lung. So is it appropriate to use this substance, because it may not in line with your objectives in hepatopulmonary syndrome, because the fibrosis occur in the liver and also in the lung. Sorry.
Thank you. Very interesting question. I can ask about that the short, because we think about that. But any toxins, what is about the not exogenous, endogenous toxins come from the other organs to the liver, and liver's the main capacity is detoxification. So, in my opinion, it's not only hepatopulmonary syndrome. It's the disorders of hepatopulmonary axis. So when lung is more severe, we should go back to the liver and identify the liver's morphofunctional integrity too. It's my opinion.
Okay. Of my knowledge, to see the real function from liver to the lung, the most frequent used animal model is the ligation, the bile duct ligation or model, which causes the liver cirrhosis, but does not have a direct effect to the lung. So you can see the axis from the liver to the lung. But
and vice versa.
Yeah, are there any difference, or what do you speculate the weakness of using the CCL4 model in this study?
About weakness of the lung?
Yeah, or the
liver.
What's the difference between the ligation model and the CCL4 model?
The differences according to gender, I show about the lung tissue, and the differences about the liver, we show that in the liver, it's the different increasing development of cirrhosis. The first more severe for male animals, because in female animals are more regenerate the livers, so that this disease delay in the female's organism. And our suggestion, we will be discussing, and the next time I hope that we study in the clinical options too, these models, and more deeper study, which the next, it will be included in the tactics of medical practice.
Thanks for the presentation. Quick question. Do you measure the ALT and the AST? Because one of the proposed hypotheses is that celemarine is antioxidant. Were you able to see any difference in the ALT, AST?
Can you speak up?
Is there any difference in the ALT and AST between the two mouse model?
ELT or EST?
Yeah.
In the small part, it will be same, but no.
Okay, thank you.
I think no. Thank you.
So, what else? I think that the Silmarin is a herbal medication which is used in the United States also, right? We are not familiar in Japan, but is it already available in your country? Or I think it's a classical herbal medication, but it's
in our country, the medication are different in other countries. So a small part I study about the medicine, and it's changed year by year. And the last year I have a small research about which medication used more, herbal or not herbal, and in our country more used used the herbal medicine in last year, but today I don't have a research about that.
okay. Thank you very much.
Thank you.
Okay. So, may I introduce my co-moderator, Dr. Ghani? So, can you?
Yeah. Thank you. I'm Rino Ghani from Indonesia, and the second speaker is Nogami Asako, with the title Early Clinical Features of Peritovenous Shunts in Patients with Decompensated Liver Cirrhosis. Please proceed, Ms. Nogami.
Good afternoon. My name is Asako Nogami from Yokohama City University. It is my great pleasure to have the chance to give a presentation here in APASLAALD 2024. I have nothing to declare for this study. For the background, refractory ascites affects the prognosis of liver cirrhosis. PVS placement is a palliative treatment for refractory ascites that is expected to improve the patient's quality of life. However, it is associated with serious complications. So, understanding the clinical course and risks of complications after PVS placement is important. This is the guideline from APASLD showing what to do for refractory ascites. Patients with grade 3 ascites while on diuretics are said to have diuretics and restrict taking sodiums. And if the patient does not recover, it is called refractory ascites. Then the patient receives LVP with albumin. And if the patient is still ill, we assess the patient as liver dysfunction. And if the patient is young or candidate for liver transplantation, try liver transplantation. And no, we consider TIPS. But unfortunately, TIPS is not covered under insurance in Japan. And there is a difficulty in receiving liver transplantation, especially in Asian countries. This is the guideline for refractory ascites in Japan. The positioning is a little changed. First of all, we do supported treatment and sodium restriction and albumin maintenance, the same as other countries, and use diuretics. And for step 5, we use another diuretics, vasopressin B2 receptor antagonist called tolvaptan. This is specular in Japan. And if the patient still has refractory ascites, we do LVP and COT, and this is the same as other countries as well. But there are limitations in patients having liver transplantations, so some patients have PVS. Aim of this study was to evaluate the early clinical features after PVS placement for refractory ascites associated with liver cirrhosis. And what is PVS? PVS is made of silicone, a very soft tube, and you put one side to the refractory ascites in your abdomen and put the other side to the right subclavian vein, and it goes through the bloodstream. There is a pump on your right side, and push the pump just to make sure it's moving. And this is the patient before having PVS placement. After PVS placement, you can see the tube here, the shunt here, and this goes over to your neck. And you can see that the ascites is decreasing. The placement kit is sold by Becton Dickinson Company. Advantages and disadvantages of PVS placement. Approximately 10% of patients with liver cirrhosis suffer from refractory ascites, and mortality rate is reported to 20%, which is not low. So the advantages of having the placement is a palliative care for patients, and they can avoid frequent abdominal punctures. There are lots of disadvantages. As loads of ascites come into the bloodstream, it causes heart failure in DIC. And SBP occurs in 0 to 42%, and heart failure is also reported to have in 3 to 16%. This is not a low percentage. The study of this design is a retrospective single-center study. The study period was from 2011 to last year, and 14 patients with refractory ascites with decompensated cirrhosis who had this placement in our hospital was included. To evaluate early clinical features, data was measured before and 2 days, 7 days after the placement. And to check the heart failure, I collected BNP and CTRs, and to check if the patient has DIC, I checked for platelet counts and D-dimers. This is the patient characteristics. This is a small study with 14 patients. The mean ages was 66.2 with 8 male patients. The etiology for cirrhosis was HCV, AIH, and APASLAASLD, and others. 3 patients had HCC, and as these patients are all cirrhosis, the albumin grades and having little elevation of bilirubin and high D-dimers and BNP was presented. I will show you the results. There was no serious complications associated with the procedure occurred in all cases. To evaluate early clinical features, data was measured before and 2 days and 7 days after the placement. First of all, the trends in BNP and CTRs, the indicators of heart failure. The trends in BNP tended to rise afterwards. The placement, it declines afterwards. And also, the CTR showed the same trends, that it rises a little afterwards the placement and declines. The same was seen in child B and C patients. Next, the indicators for DIC, I looked for the plate counts and D-dimers. The plate count tended to decrease transiently but improved in a week. It was the same trend in child B and C patients. Trends in D-dimer show that it rises transiently, but in most patients, it declines in a week. One patient here having D-dimers rising had another problem, another disease in a week. Last, the PVS, patency, and complications. These are all the data of 14 patients. In our study, we had more than 10 patients who had older than 65 years, meaning that the patients could not have liver transplantation in Japan. 4 were quite young, but having low MELD scores and was not candidate for liver transplantations. The existing date and lifetime data are as shown, and the cause of death was colon cancer, liver failure, infections, and so on. Diuretics dose for daily had a tend to decrease after the placement. This is the data for PVS patency and survival rate. The mean patency was about a year, and there was no significances in patency between patients with child PUB and C cirrhosis. The median survival days was 474 days. Discussion. There still has a need for a decompensated cirrhosis patient who cannot receive liver transplantation because of age, living countries, and low MELD scores. So we thought that the understanding complications and patency rates are important. This is the data from International Registry in Organ Donation and Transplantation, deceased donor liver transplantations in the world. In the US, and especially in Spain and European countries, there are about 40 patients of donors per million, but in Asian countries like South Korea, Hong Kong, China, Thailand, and especially low donors in Japan. It means that there is a difficulty in receiving DDLT in Asian countries. Deceased donor liver transplantation in Japan is as shown. The waiting time is long. The mean waiting time is 466 days, which means that it's very long for patients who are willing to have liver transplantations. And only 4% of patients can have liver transplantation. So there are lots of patients who are suffering from refractory ascites. Summaries. Markers suggestive of DIC and heart failure change early after PVS placement but tend to improve, so to monitor patients for a few days after placement is important. The average patency after implantation is about a year and 470 days until death, and may be a good palliative care method for non-transplantate patients. There is a limitation that this is a retrospective study in a single center with very small populations. Further investigation is needed. From this study, we conclude that PVS placement for refractory ascites is a technically feasible palliative therapy, evaluating changes of CTR, platelet counts, BNP, and D-dimer levels may be useful for early projection of the efficacy of the placement. Thank you.
Thank you. Is there any questions from the floor? Yes, please.
Hi, so thank you for the very interesting presentation. It's nice we don't have this device. We don't use it a lot where I come from. The question was, there was one patient who died from cardiac congestive heart failure. Is that correct? Or
the patient, I think no.
No?
But one patient had the elevation of D-dimer, which had stroke.
Oh, so there was no death from congestive heart failure. I thought I saw that on the table.
Oh, no.
No. So then the question is, do you think, apart from what you did, the BNP and the CTR, do you think like echocardiography would be useful to detect those patients who have latent heart failure? Because we know from hepatovenous shunting that this happens, that you do see heart failure due to the fluid shift that happens briefly. So would you use that echocardiography to see if patients are more likely to develop heart failure after implantation? Thank you.
That should be great, but it takes a long time to do the echocardiography, so it might be not available in all patients, but it should be a good marker. Thank you.
Okay, thank you.
Thank you for the very interesting presentation. Can I check in terms of the patency that you track out? What is the time sequence for patients to still require large volume paracentesis with regards to patency? So is that the patency curve directly related to whether they still need paracentesis?
Thank you for your question. I'm not sure if it's associated. Some patients had the shunt obstruction. Those patients had short patency, but I'm not sure if I'm answering
So
correctly.
how do you measure your patency? Is it a technical assessment, or does it go by whether the shunt is still working or not?
Working or not. And if the shunt is not working, the patients are told to come to the hospital.
I see. Okay, great. And then, as a criteria, do you assess the cardiac function before you do your shunts?
Oh, yes. Actually, we do not do PVS placement in patients with heart failure.
Okay, but without echo, that was what I was discussing now, just clinical assessment.
Yes.
Okay, thank you.
Yeah. In your case, the use of peritoneal venous shunt is to control the ascites, if I'm not mistaken. Yeah. I think the study also should include whether the ascites is controlled or not, and also maybe the impact of the control of ascites, such as the hepatorenal syndromes or dysfunctions of kidney, maybe should be included. So I wonder why in your study you measure the BNP and the dimer, but not clearly reported the control of ascites.
Thank you for your question. I think I should do that.
Oh, okay.
And this will be in the further job of me. Thank you.
I have a question and two questions. One, the first is the DIC associated with this procedure. It's almost happens almost all cases. So I wonder, you already use some protective medications not shown in the slide, or like anti-inflammatory or gabexate, or
We used gabexates, but not anti-inflammatory drugs. Thank you.
okay. And then the second is that I know that the tips is not allowed to by the what do you call the hoken insurance in Japan. So it's difficult to compare, just compare the tips with PVT. But can you speculate which is some advantage in this method to the other?
PVS placement's greatest advantage is probably that it's covered under insurance in Japan, who cannot have liver transplantation. If we could do tips, we'd like to do and try, and would like to know which is better really in the real world, clinical based and clinical. But as you know that we cannot do tips in Japan, it's very difficult to do publicity for me.
Yes. Okay. Yeah. Okay, so if there is no other questions, okay, thank you very much for your presentation. Thank you.
Thank you. Thank you.
The one speaker could not show to the presentation, so this session is now closed. Thank you very much.
Thank you. Thank you very much.
Um,